Welcome to ASRS's Journal of Vitreoretinal Diseases Authors Forum. I'm your host, Dr. Timothy Murray, Editor-in-Chief of JVRD. On each episode of the JVRD Authors Forum, I will interview innovative retinal researchers on their studies featured only in JVRD and how these studies will impact our patients' care in our clinics. Tune in to hear directly from investigators about the clinical implications of the newest and highest quality research in the field of retina. Welcome to JVRD's Author Podcast. Today we're joined by two vitreoretinal specialists from the Retina Group of Washington, Dr. Mohsin Ali and Dr. Jeanette. And we're going to focus on their recent manuscript, Low-Dose Atropine Drops for Symptomatic Vitreous Floaters, a Non-Invasive, Safe, and Effective Therapeutic Option. Welcome, Dr. Ali and Dr. Du.
Thanks for having us.
So pleasure to have both of you together. I love you on a single screen. It's a lot of fun. This is a fun paper in a way because those of us in busy clinical practices have to deal with this over and over and over again. So tell me a little bit about what drove you to thinking about this process, and then what led you into the initial design.
Well, Dr. Murray, it's exactly how you described it. This was a project that came out of our experiences in the office. We have many patients that come to us that have persistently symptomatic vitreous floaters, and we have historically advised patients for the vast majority of them. And when we don't advise patients, then our next therapeutic options are potentially invasive or potentially dangerous options, such as a pars plana vitrectomy and YAG vitreolysis. So there's a void between doing nothing and doing something that is a procedural intervention that could cause potential harm. And we noticed in the clinic that there are patients that will tell you that, hey, now that I'm dilated, I don't notice my vitreous floaters as often. So if you take that clinical experience and use extrapolate from our pediatric ophthalmology data, we decided we would try low-dose atropine to see if we could mask the perception of symptomatic vitreous floaters and provide an option that was in that void between doing nothing and doing procedural intervention.
So, it's interesting because to me, there's a very small subset of patients that are truly impacted by their symptomatic vitreous floaters. And usually we can just talk our patients through. What did you do for patients that had unilateral floaters and nothing in the other eye? Did you use atropine in both eyes? And how did you approach people that were not yet presbyopic? So knowing that there was some potential to impact, accommodative function.
There certainly are a fair number of patients who just have unilateral floaters, and they're actually the majority of the patients that we prescribe the drops to are using it in just one eye, their affected eye, with the knowledge that, we tell them the mechanism of this working does have to do with obviously pupillary dilation. So, if they have work that requires them to, look like they have even pupil sizes, that may not be something for them to consider. And also, presbyopia and inability to accommodate, or sort of a decreased ability to accommodate, is potentially one of the side effects that we discuss with them before they try the drop. In the study, we found that the percentage of patients who did report a slight decrease in their ability to do near work was it was about 4 patients out of the 22 that completed a week of drop use.
It's hard to get my patients, at least when I want to atropinize them, to use this long term. So was your idea that you were going to space this through the initial symptom period and hope that maybe the symptoms would decrease and you could taper them off meds? What was the thought process in the design?
Well, we tried to include patients who had already been through the acute phase, meaning one of the exclusion criteria were folks with acute vitreous detachment within the last 3 months. So patients had to have chronic symptoms before we would give them the medication. So it wasn't just to get them through the acute period. It was to deal with their chronic symptoms. And then the idea was to allow them to use it indefinitely as long as they wanted. Or we found anecdotally in our experiences, even outside the study, that many of these patients will use it as a temporizing measure. You find that they come back to you maybe a year or two later and they say, you know what, I used the atropine a lot in the beginning. And then after a year or so, I found that I didn't really need to use it as much. So maybe those individuals either had an improvement naturally in their vitreous floaters that allow them to wean themselves off of the atropine. But there's other patients that continue to use it on an ongoing basis. There's also some of my patients that will use it as an as needed approach. So some of my patients will, for example, have multiple monitors at work. And when they swing their head from side to side from one monitor to the other, they notice the floaters go by and they use it only during working hours.
Interesting. And then your design of your study to incorporate, since this is assessing symptomatology, tell me about how you chose your survey material.
So we used a modified NEI visual function questionnaire, 25 questions. And really, the questionnaire assesses a number of different things related to lifestyle, issues with driving, issues with near work, etc. But the two main questions that we were primarily focused on was whether or not patients felt that the drops helped with the floaters at all, and whether or not they would feel like they wanted to continue the drops. And so those two questions were really sort of the crux of what we were looking at as our primary outcome.
And when patients didn't want to continue, what were your feelings about their most common complaints?
The primary reason why patients did not continue the drops was that the drops didn't work. So about 30 to 60% of the patients, depending on how you splice the data, found that the drops were effective. And in those individuals where they just didn't see any improvement, they stopped using the drops. We also found that as Dr. Du mentioned earlier, about 18% of them mentioned that they had some issues with photosensitivity or blurred vision, either near or far. But those actually were not the main reasons why they discontinued the medication.
And Doctor, you alluded it to a little bit, was the fact that unilateral dilation. I'm always concerned when that's the case because I always think of what's the worst case scenario, and that's a car accident or a bad fall, and you're in the ER and you're not thinking to really tell them what's going on. Did you give them a carry card or anything to help identify them if they were seen emergently?
Well, remember that it's 0.01% atropine. So we intentionally chose the lowest pediatric dose of the atropine so as not to induce a significant pupillary dilation. So we're aiming to have a mild, maybe 1 or 2 millimeter pupillary dilation that will give them symptomatic relief, but avoid many of the side effects, including the pupillary dilation that would cause issues with vision or stereopsis.
There is a variation in the amount of dilation that each patient experiences, and that, whether or not it depends on age or iris color, we think that, in the future, having larger studies to kind of parse out how effective these drops are for different patient characteristics would be informative.
So now that you guys have the study and really, very positive results overall for that group that was responsive, how have you extrapolated your study into your actual clinical practice? What are you doing now with this data?
I utilize the drops pretty frequently now. So if I have patients that meet those inclusion criteria, meaning they have either a chronic posterior vitreous detachment or vitreous synovitis even without a vitreous detachment, and by the Van Herrick method, they don't have narrow angles, and they find that the floaters are debilitating in their day-to-day activities, then I usually offer them the option of trialing the low-dose atropine drops. Most patients will find that they're willing to try this prescription only because there's not much to lose. And even those who are thinking about a procedural intervention, such as a pars plana vitrectomy, like the idea of trying medical management before they choose a surgical approach. I also like to try something medical before I choose to do a procedural intervention on these patients.
Well, I love this because I'm like you. I think being able to offer a conservative step before you're going to an invasive procedure makes a lot of sense. And I find for many of my patients that their symptomatology, even what you're calling chronic, will drop out over progressive intervals of time. So for me, the idea of using this as a temporizing agent, avoiding potential, invasive surgical management, and then maybe being able to come off sounds really exciting. So I'd like to thank both of you, Dr. Ali and Dr. Du, for joining us today and talking about what is an incredibly clinically relevant paper. And I want to congratulate you on how well you designed and carried out your study. Thank you.
Thank you, Dr.
Thanks for having us.
Thanks for tuning in to the JVRD Authors Forum. You can watch and listen to more episodes on the ASRS YouTube channel and on popular podcast directories, including Apple Podcasts and Spotify. Visit www.asrs.org/JVRD forum on the ASRS website to learn more. See you soon.